Welcome to today's Digital Health Seminar Series talk. Should I introduce all of us, or do we know each other by now? Okay. Okay, so we're the team that organizes the seminar series. So we've got Mikkel, Matt, Emily, me, Nareed, and Emma. And today we've got Christopher Baleke with us to talk about a digital health record system for mothers and children in rural Uganda. First, some housekeeping. So please register your attendance if you've arrived in person using the tablets. The webinars will be recorded and made available online. Online attendees, please stay muted during the presentation, and then there'll be time for some Q&A at the end of the talk, so you can use the chat or raise your hand. So we've got Christopher Baleke presenting today from the Mayuge Institute for Global Health Sciences, Research and Innovation, and at the University of Bristol. He is a postgraduate researcher at the Bristol Medical School, and he's pursuing a PhD in the Molecular Genetic and Life Course Epidemiology program. He is also the co-founder and organizational lead of the Mayuge Institute for Global Health Sciences, Research and Innovations, a social research enterprise in Uganda. And his research interests are maternal and child health, as well as infectious disease management and application of advanced statistical methods to evaluate public health interventions in low and middle income countries using real-world clinical data. Yay, cool. How do we get his? No.
Another
Next problem.
Yeah, no, there is another tab.
Okay.
This one, yeah. Here.
Okay. I'm just going to do this.
Okay. Yeah.
Good.
Yeah.
Okay, thank you.
Wow, thank you very much, everyone, Sarah and Miguel, for the wonderful introduction. Yeah, I'm very excited to be here to this team, the Digital Health Seminar Series. I just heard about this group recently by MIHRI, but I found it very interesting, and she's the one who recommended me and directed me to this group, and was like, I need to get in touch with Miguel and see if I can get a slot to come and present my work. But yeah, so when I checked about the website, and everything was in line with what we want to do. I'm Christopher, like she said, and my PhD may be, to begin with, I'm looking at how maternal health trajectories during pregnancy affect the future risk of developing cardiovascular risks, diseases. And I'm in my second year of the PhD. I'll be using mainly electronic health record data from the UK and Uganda, as I will be showing you later. But for today's purpose is to look at how we are planning to develop a digital maternal and child health record system in Uganda for a linked birth cohort. And for that purpose, this presentation will talk about, first of all, our institute, which is MIHRI. I'll also give you some background about maternal health status and child health in Uganda, and also the status of digital health infrastructure in Uganda. Then talk about what we are currently doing and our next plans, but also share and ask for support that we might be interested in during the kind of work that we are doing. So MIHRI, as I say, it goes Mayuge Institute for Global Health Sciences, Research and Innovation, was started by a group of early career researchers from sub-Saharan Africa, trained in epidemiology, medical statistics, public health and medicine, coming from 5 countries, that is Uganda, Kenya, Zambia, Nigeria, and Botswana. And here in the picture, some of the group members at the hospital where we are based. Our interests are in maternal and child health, and we're interested in creating a large data set for supporting research, training, and innovation, specifically for evaluating public health intervention in Uganda. So I don't know how many of us have been to Uganda before? No one? Yeah. Well, I bring you here Uganda in picture and in person myself. And we are located, Uganda is in Africa. in East Africa to be specific, as you can see on a map. But in Uganda, we are located in eastern part of Uganda, that is Busoga sub-region. This region is one of the, is one of the region with the highest fertility rates. It's one of the poorest regions in Uganda. It's located along around Lake Victoria. If you've heard about Lake Victoria, the main activities in this area is actually fishing and sugarcane plantation. There are lots of healthy and socioeconomic challenges in this area, which put populations at risk of infections, and especially girls getting pregnant as early as 14 years and 13 years, 15 years. Of course, that has implications to the outcomes during delivery and the future. So when we formed the institute, that is MIHRI, we had that interest of working on maternal and child health, but we had to look for an area or hospital that would collaborate with to support our research activities. And so we found St. Francis Hospital, which is also in that area of East Africa, Eastern Uganda in Mayuge district. We engaged with them, asked for collaboration, and successfully they accepted to work with us. This hospital is a private one, not for profit. It is the only hospital in that district. And it provides a range of services, maternal and child health. It has good infrastructure, as you can see. And this means it can support collaboration activities, wide range of number of patients visiting every day in the maternity, antenatal, and deliveries. And the beauty with this hospital is that it is neighboring a government hospital, which is also in the same area. And what happens is sometimes mothers attend antenatal care in the government hospital, which is Mayuge, and then end up coming for deliveries in this private hospital. So that is an opportunity for us to see that we can link their records across these two facilities, since we're aiming to create a linked birth cohort. So the status of maternal and child health in Uganda is still bad, just like in other sub-Saharan Africa. These are not surprising statistics, but they are actually true. Every year, about 1.5 million babies are born in Uganda. And of course, Uganda is one of the countries with the highest fertility rate. So with these babies being born, it means a large number of mothers have risks of birth. And with this, we see that about 15% of these deliveries happen in the villages, not even supervised by any medical person, sometimes in a home, sometimes in a traditional birth attendant. But in the recent days, we have seen, recent decades, we have seen progress in maternal and child health indicators. These are the key indicators normally, that is maternal mortality, neonatal, infant, and under 5. So we've seen maternal mortality reducing from 3.36 to 2.28 per 100,000 live birth, and neonatal from 27 to 22, and like the figure there. But with this improvement, still these rates are high compared to what we expect with the global targets. And besides looking at those deaths, we've seen that in sub-Saharan Africa, the leading causes of those maternal mortalities are quite similar to those that in Uganda, including abortions, hypertension, and hemorrhage. And these don't happen during the delivery itself, but they start happening at the time of pregnancy and before. But on the side of maternal on child health, we have also seen that in Uganda specifically, malaria, anemia, neonatal conditions, and pneumonia are the leading causes of child mortality. If you can see the trend from 2018 to 2023, although the rates are declining, but still significantly high, these babies don't deserve to die before they mature. So where are we looking at the mothers and babies and children together is because there is a direct link between maternal health and child health, in that the mother's health significantly influences the risk. I mean, the risk of the child surviving their 5th year or dying within 5 years. If a mother has had poor pregnancy poor pregnancy outcomes, they are likely to produce babies with low birth weight and preterm babies. And these babies have high risk of developing infection because they will have low immunity, and they will also have risks of developing anemia. Yet these are the main conditions we saw that are leading to death of these babies. But besides the mortalities in maternal and child health, if the mothers survive death during their pregnancy or during birth, it doesn't stop there. They also have chances of developing cardiovascular diseases later in their life. And these conditions are related to the birth problem they experienced. If you look here in the picture, that some mothers tend to have problem like obesity or hypertension before pregnancy, but when they become pregnant, they have higher risk of developing adverse outcomes just because of their maternal history. And these adverse outcomes, including stillbirth, including abortions, including gestation diabetes, they are likely to increase the risk of these mothers developing cardiovascular diseases later in the future, including hypertension, including heart attacks. But these conditions in the recent days have become very popular in developing countries, but not so popular in our settings. Like the governments, like even the Minister of Health, are not so much focusing on these conditions, but they are only focused on the immediate birth outcome that are the mortalities. But as we can see, that maternal health also can shape the risk of the future adverse outcome. And the opportunity here that we would have is if we're able to measure the conditions of these mothers before pregnancy, during, and after, then we can easily predict the risks of developing cardiovascular diseases in the future. And where the challenge comes in is that the data that we'll be using to predict those risks is not available in our settings. So in other countries, like in the UK, they have been able to use routinely collected data in the electronic medical records to try and do exploratory analysis for these mothers in real time during pregnancy and delivery, and they can be able to predict future outcomes. It means if they can predict future outcomes, they can then intervene immediately with interventions and try to reduce the risks of those complications, either causing death or causing long-term chronic conditions. We have models like the Q-Risk3 model, which is used by the UK here, ministry, the health department. They use this model to predict the risks of cardiovascular diseases and then intervene immediately. But these models have not been applied anywhere in our settings. And reason being, there is no data to try test these models and then make them being used. So when we look at the main sources of data that would be supporting this monitoring and predictions in Uganda, we have the National Health Management Information System, which is mainly used in hospitals, but this system is mainly in paper-based. Patients report every day to these hospitals, and their details are captured in these registers. We have, for example, the antenatal, the delivery, and the postnatal registers. So these registers are not coordinated, like they are independent. The systems, that is the HMI tool, the government has tried to convert it into an electronic version so that their data can be collected electronically. And currently in some of the main hospitals in Uganda, and those are the regional referral hospitals, they're trying to use it, but still with incomplete parameters. Some of the variables in the system that are, in the hard copy register are not yet added into an electronic version. So it means it cannot still work. The other source of data that we have is the demographic health surveillance, which is, of course, done globally every 5 years, like in Uganda it is done. This surveillance collects a lot of important data that is socio-economic. They also do some measurements of height and weight for general population sampled all over the country. If we had the chance of combining data for these two systems, would make great impact. But the challenge is all of them are not linked. The HMI system, because it mainly collects patient data and then remains in the hard copies, the one that is converted into an electronic format is mainly for reporting purposes on key indicators and key outcomes. That cannot work. So our challenge is seeing these tools, seeing this source of data not linked together. And one of the reasons for not having them linked together is lack of a national identification number, which we have, the government introduced about 10 years ago, but this national identification number is not being used by most of the people. Patients report to the hospitals, but they don't go with their national ID numbers. In the registers, it's supposed to be filled like every patient to record their national identification number, but it's often not recorded. So it creates a big challenge in terms of linking these data sources. So the WHO, of course, has been recommending early risk assessment and timely intervention, and they have been recognizing digital health tools as a way to improve health systems and universal health coverage. Addressing the data gaps would be the priority by using these digital health tools. So, of course, the government of Uganda has been trying to improve the digital health system in Uganda over the years. And recently, that was in 2020, they launched a health information and digital health strategic plan 2020-2025. This plan, the strategic plan, was developed in order to support implementation of sustainable digital health systems in Uganda after seeing the challenges that I already mentioned. And their priorities was to improve digital health information, improve research and innovation. And one of the key targets that was interesting was by end of 2025, which is this year, they wanted to have patient-level system being implemented at all points of care. Very interesting. But if you go back to check on this, I'm just waiting to see the report of this strategic plan, see how much they have maybe achieved. I don't think they have achieved much, but I'll wait because I've already been seeing in the facilities what is going on, and it's like maybe not even 50% of their target has been achieved. So currently, even this strategic plan has been able to observe the digital systems that are being implemented in Uganda, both in private and government facilities, but mainly these systems are collecting aggregated data. And this aggregated data, of course, cannot be useful for research purposes. We need patient-level data. And other systems in place include OpenMR, Clinical Master, Uganda MR. There is another one for integrated disease surveillance and response. But all these are mainly collecting aggregated data, not patient-level data. So the challenges that we have been seeing in Uganda are hindering the progress of digital health are not actually new, but these are things that we will expect, including limited qualified staffs at all these health centers, especially in the rural areas. And there is a lot of duplicated health information systems. Like I've already said, like every hospital will develop their own tool, another private hospital will develop their own tool, and they operate uncoordinated. And also, there is no effective mechanism for harnessing research and innovation in relation to digital health. haven't seen any program in Uganda that is actually enhancing research and development in digital health. And most important, of course, is the funding. The government has not put in enough resources to operationalize even its own strategic plan. But other than that, also the infrastructure, which is also come back to the funding. Like health facilities don't have internet access, they do not have computers. The internet coverage in Uganda is still less than 40% all over the country. And most of these systems really need internet if they are to survive, or they need computers. They cannot operate without these key items. So even with the different tools being implemented by different facilities, or whether they are collecting aggregated data, these different systems are not linked. Each system is operating on its own way. Or we have systems that are standing alone. For example, we have the HIV digital tool for tracking HIV care. It has patient level data. And we also have the TB digital tool. These tools are independent, they are not coordinated. If we had the mechanism of harnessing this data that we link the patient from HIV to maybe TB and all other programs, then it would make sense. But they're all standing alone, they're all not compatible with each other, and that one makes it more worse. But with the challenges still, I can say there are some laws and policies that have been put in place. That is, if we wanted to implement something related to digital health, we have policies like the Data Protection and Privacy Act, which was formed in 2029, Data Protection and Privacy Regulations. All these were put in place to try and enhance or improve the status of digital health and information systems in Uganda. But they're not really bringing out what they would do. And the other beauty we have at the district level and community, we have existing systems that are being used by district to report health outcomes of the ministry. But as I said, all these ones are reporting aggregated data. But of course, they are good for us to benchmark on and improve the systems within the district. So after seeing all those challenges in relation to maternal and child health and the digital systems, we as the Institute came up with this model, and we want to do maternal health, creating this linked birth cohort, but following a continuum of care, looking at the mother from the time of preconception to pregnancy and beyond birth. And currently, like I said, that the data for the mother and the child is separated. Yet the outcomes for the child are so much dependent on the mother. So we can't do predictions for for child health outcomes without having these data sets coordinated. And what we want to do is create this cohort whereby the data for the mother is collected from before pregnancy using digital health records until maybe 5 years of the child, but when they are linked. And currently, the data, if you were to use it, you can only use it cross-sectional because there is no link between the antenatal, for example, registers and the maternal registers plus the postnatal registers. If you wanted to go and track a single patient who was registered in the antenatal register to check on their outcomes during delivery, you will not be able to get that because there are no unique identifiers. Or the other thing is they are in heaps of registers which you cannot actually collect. So the two hospitals that we identified are within the same area. So what we want to do is to create this system whereby if this patient goes to any of these hospitals, we can still harness and collect this data and merge into one system, collecting all their personal data, all their health information, all their examination, the lab records and all that, and then have it into one system. And then it would support maybe prediction models and evaluations of intervention that are being implemented by the government. So to do that, we had a plan and we're like, we need to do co-design. To co-design this digital maternal health system. But co-designing it, what do we need to do first? We need to look at the current status of the medical records in these facilities. Look at how they are recorded, look at which variables they normally register, look at the completeness, how that can act as a baseline. Also look at the infrastructure in terms of how the data is stored. Then after that, we would design a digital health information system focusing on maternal and child health, pilot it, and then refine it together with the healthcare workers, the patients, the Ministry of Health, in digital health, and the district. So currently, we are at this stage of reviewing medical records. And at this beginning at the end of last year, that was 2024, we thought we would do a medical review to understand the records in antenatal, delivery, and postnatal. And specifically, I wanted to do a review of data types, understand the storage methods, understand the variables that are being captured, while comparing this with the national and the global recommendations, then audit the pregnancy-related health data for completeness, and also try to understand the feasibility of linking the pregnancy data from pregnancy to postnatal, see whether there are unique identifiers that could help us link this data. But before we did that, we were like, let's first go and do a feasibility and see whether this data can be reviewed to understand all whatever we wanted to see. And of course, as expected, we realized that data was not in electronic format. It was in hard copy, like you can see. And the maternal patient registers are so big. So using this data, it means that we would need to extract it into an electronic format. And then what we also found out that there was an opportunity in these registers to record unique identifiers, like the national identification number, which I talked about earlier, plus the patient numbers. And these numbers, if they are recorded in these registers for every patient, they would help us link the patient data. So after doing that feasibility study, we developed a protocol to support the extraction, and this was registered with the Uganda National Council for Science and Technology. It was approved in March 2026, and we selected two health facilities, that is St. Francis and Mayuge. One is a private and the other is a government, as I've been showing you. And we aim to extract records for the past 2 years. Why the period of 2 years is because we want to see whether we can easily link mother's record from pregnancy to delivery, and putting into account of the 9 months of the pregnancy, and not knowing at what point within the 2 years period, some mothers might be captured in those 2 year period, but they haven't been delivered. Or some mothers were captured during this period of 2 years, but they had delivered before that. So we had that period of 2 years to make sure that we get some numbers who got antenatal within the period of 2 years and also delivered within the period of 2 years. So we needed to create a digital extraction tool in RedCap, and that was successful. We didn't have, of course, a RedCap system. We liaised with one of the partners in Uganda to give us a server for hosting our RedCap. And then after that, recently, that was in June, we started our data extraction with very limited resources. Of course, we do not have any funding. We are just basing on individual donations, for example, getting the tablets that we were supposed to procure, having those meetings, buying data, and all that facilitation. But yeah, we have a team of 7 for data extractors who have been able to transcribe data from the registers into RedCap. We have a data manager who is supporting us part-time, the quality control, and the project supervisor. And in terms of our quality management, we review every record comparing with the register with that that is being captured into the system. We're also doing 20% double entry for all our records to make sure that we have some accuracy. And concurrently, we continue to do quality, review and address all queries that arise during the extraction. So what is the progress so far with our data extraction? We have so far extracted over 10,000 records. And some of the observations we are seeing, they are unique identifiers that we expected, like the class number and the NIN number, but these have quite a lot of missing data. So it means we're already seeing a gap in terms of linking our records if you wanted to do. And the client number, which is given at the facility level, is a number for antenatal. This number is supposed to be recorded in all the 3 registers of antenatal, delivery, and postnatal. But we've observed that this client number at some point is being given by more than one patient. So that is a big challenge. It means we might fail to link those patients who are sharing the same number. And the other challenge is, even though there is provision for these client numbers, in the postnatal register, this client number is not being captured. So it means we cannot link the postnatal data with that of maternity and the antenatal. We can easily link the antenatal and maternity, but also with limitation that some patients are missing these numbers in the records. So as you can see, this is the antenatal register. The client number, which is very important, we have about 5% of the patients missing this number in the record. For the national identification number, which would be the most ideal one, almost none has this recorded. 90% of the patients are missing this national identification number. It's a big problem. And then with maternity, it is the same thing. Now here it becomes worse because we expect to use this client number to link the patient from antenatal to maternity where they deliver. But guess what? 80% of them are not having this client number recorded, so we cannot link them. It is the same as with the national identification number. Only about 3% are having it captured. That is very small. So it makes it very hard for us to link these records. We also looked at the data types, try and see how they record them. One of the key indicators for cardiovascular diseases is measurements for protein and glucose levels. These measurements, by standards, are supposed to be captured as continuous in terms of milligrams per deciliter of blood, or that is protein, and also millimole per liter of blood, that is glucose. But what we found out is that instead of recording these results as millimoles, they instead categorize it to either reactive or non-reactive. This also makes sense clinically, but it doesn't give us the severity. If someone has high levels of glucose, it does not give us how much severe it is. Or if someone doesn't have the markers that indicate glucose, it doesn't give us the thinking of, are they about to tend to have high glucose levels or not? So these are all challenges that we are finding out in the data, and we believe that our project would be doing a lot to improve all this. And now our next plan, as we continue with the data extraction, we hope it will be done by end of January, and we'll write a comprehensive report about that data in terms of the quality, in terms of what can be done to improve that. And then our next plan would be now co-designing this MIHRI tool. We want to do this together with the patients, with the healthcare workers, with the district healthcare team, the Ministry of Health, policymakers in digital health. And our first objective within this digital health co-design is to review the existing electronic health records tool in Uganda, benchmark on those ones that have been used, learn from the lessons, see which ones are ideal compared to our setting, because we know that some of the systems might require internet to operate, whereas others may not need internet, or you can need internet for a time when you need to upload the data on the server. So the second one, we want to engage these patients, I mean the healthcare workers at these facilities, and hear from them about what would be the motivation for them to adopt the use of this electronic health record system. Because we've seen in other settings where the system was introduced in hospital setting and healthcare workers were not interested in it, creating a lot of, giving a lot of issues that maybe the system not working, it is slowing up their speed, or it is bothering them a lot. So we want to meet with the healthcare workers and hear about their motivation for using it, and then engage them still in the designing and developing of this system in terms of understanding the patient workflows. When the patient arrives at a facility, before they go for screening in a clinical room, where do they start from, and then create all that flow. And then after that, we want to develop a comprehensive maternal and child health variable list mapped based on WHO ICD, that is the international code of disease classification, and also together with the Ugandan Health Information and Management System, compare the two and create a comprehensive variable list that is now to the national standards, as we've seen before, that the proteins and glucose are being reported in a different standard. But the WHO and ICD code expect something different. So that's what we want to benchmark on, meeting with experts in maternal and child health, and then refine that variable list. The other one, of course, we want to develop that system or the prototype first in hard paper sketches, and then do maybe in Excel, and then we can now do a digital one on the system, pilot it and test it, and then later we can, if it feels like after testing it, then we can assess whether it is feasible, assess its usability, the data quality, and see how much of the linkages we have been able to create while using this system. And then after seeing its success, we can draw a roadmap for maybe scaling it up in Uganda, or meeting up with the ministry to ask them to look into it and see whether we can work with them and have it rolled up maybe at the national level. And so with the code design, here is where we are, and most of the technicalities in this code design is what we cannot do as a team in terms of about our team, because most of us are maybe clinicians, we are epidemiologists. No one has expertise in in digital health systems. And that's why I found this seminar series to be important for us, in that maybe we could get people who have interest in this kind of work, or even connecting us to someone who might be interested in this kind of work. And then we work together in terms of maybe looking even for funding and all that kind of stuff. So with that background, we also wanted to see, in terms of the infrastructure at these two health facilities, how is it currently to see in terms of electricity, in terms of the system that they have used, in terms of the hardware, like the computers. And that is Mayuge Health Center. We found that they actually have electricity and a standby power source, that is a generator. Unfortunately, they don't have an IT person. They don't have internet connection at all. They don't have computers. They only have one computer, and that is supporting the HIV care department. That is a very big gap in that hospital. They have used medical record system before in that hospital. So it means if you wanted to implement a new one, or to bring in something together with them, they can easily contribute, because they are familiar with some of these systems. Then with the other facility, which is St. Francis, this remember is a private one. It looks a bit better compared to the other, because for them at least they have an IT person. They have also electricity. They have internet connection most of the wards in the hospital, and they have Wi-Fi in all the sections being connected. They have sufficient network speed, because we have tried to test that. And the IT personnel is available all the time during the day and off work to support any challenges related to IT and maybe computer challenges. So I think this background of the facilities also is helping us to understand where to start from, or would be communicating to anyone who wants to, or might be interested in working with us, to understand very well the setting where we're coming from and where we would need and what we would need in terms of resources if we are to start this project. So meaning that based on those challenges that we've seen in the assessment, the kind of support basically that we would need would be technical support in digital health systems, development, management, things to do with servers, data storage, and also maternal and child health experts that can help us to refine the variable list. All this we know that requires funds, not only the technical expertise, but money. For example, if we need to run those co-designing workshops with the patients and healthcare workers, we would need some money to facilitate that. Money will be required to put in place computers and have them installed in different departments, and also money for setting up these data server networks would be needed. So we haven't found any potential funding, maybe networks or schemes that would reach out to or submit our concept. Currently, we're working on finalizing our proposal for this co-designing protocol. I talked about before MIHRI, who introduced me to this group. She was able to get us to another person called Guy. He's working with in Malawi, has also been working in digital health systems. We have met him like 2 times, and he's trying to support us, also look for networks from different areas to see if we can get people to work with us and support us build the system. And yeah, so I hope by coming here, we would be able to get some answers for some of these challenges from the team here and anyone who will be listening in. And yeah, thank you much for returning. And I'd like to acknowledge, of course, MIHRI, who referred me here, and Tagai, plus the team. Thank you very much.
Shall we go for questions now? Maybe I can start with what? Anissa? As you say, some of the hospitals are currently just annotating everything by hand, and then you are proposing to add computers in some hospitals, for example, in the hospital you were mentioning now. But that may require training, and it may disrupt how they work, no? Then, yeah, I wonder how that can affect their workload if they are already busy. I'm not sure if they probably are busy because hospitals are always busy, no?
Yeah.
Then, yeah, I don't know. Did you consider that, how that may affect them? If they will need some training and they may not want to use the new system because they don't see value on it. Yeah.
Yeah, so I think that's why in the co-designing process, we would want to involve these healthcare workers from the start, because right now we haven't started at all. But from the start in developing, we want to engage them and see how would they want the system to be implemented, maybe in a phased manner, or which kind of training they would need for them to adopt the system, or maybe compared to the system they have used before, what would they want to see improved if we were to introduce a new system? Yeah, so basically this co-designing, I believe, will help us to bring them together as a team, not for them to feel like it's us coming with our system and we want to enforce the system on them. We want them to feel like it's going to be of benefit. And for one reason, that's why we did this baseline data extraction, which we're currently doing. We want to show them the the limitation that are in that system that they're currently using, the hard copy, because in some way, the hard copy system is also wasting time with them, because I've seen most of the records being captured in the register, maybe like 2 times, the same variable, maybe age being captured in maybe in an antenatal screening desk. At the same time, it's captured in the lab. At the same time, captured in another, but for the same patient. So by bringing this system, which is going to be linked across the department, somehow it will be saving maybe their time to repeat the entering of the same data in different departments. So showing them all that maybe can attract them to accepting the system. Yeah.
Can you talk more about the organisation that you co-founded, MIHRI, and how that relates to the PhD project?
Sorry?
Can you describe more about the organisation that you co-founded? Is it called MIHRI?
MIHRI, yeah.
MIHRI, and how that relates to your PhD project?
Okay, so this currently the data that we're extracting under this project, I'm going to use that same data for my PhD. I don't know if that makes sense, because I'm using electronic health data for my PhD, electronic health data from the UK and from Uganda.
Oh, okay.
But in the Ugandan data, I'm using the data that we are currently extracting under this project. So we are collaborating with MIHRI to do the data extraction. And actually, as of now, we are working on a data sharing agreement between University of Bristol and MIHRI and St. Francis Hospital, so that when the data is extracted, they will do cleaning it, and then we can see which records I'll be interested in, and then they share with us the identified data, which will contribute to my PhD work.
Okay.
Yeah.
So the early career researchers that are associated with MIHRI are the ones that are doing the data extraction from the paper records onto the electronic system.
Yeah. Actually, it was really nice to add on to that, because discussing with my supervisors were like, I think this work is directly related to your PhD project. So it means you can get some funds from your research budget to facilitate the data extraction that is going on in Uganda. And that was allowed. So right now, as we work on the data sharing agreement, after when it will be done, I can be able to get some money to recover for the costs of data extraction in Uganda. Yeah.
And just a comment that I remember in some event organized at the University of Bristol, in which somebody presented a collaboration work with a third world country, that they were introducing lighting in people's home. I think one of you were in that session, but I don't remember what was the name of the academic that was involved into that work. But there was some academic being involved with some third world country implementing some new technologies and seeing its adoption. And he was using some specific funding for offered by University of Bristol, but I don't remember the funding, I don't remember the person, and I don't remember the event. But I need to check. I need to check back. I was just hoping that
speakers from one of the speakers was
no, not for the seminar series. It was I don't remember which event was. Maybe the pump priming event, but I don't remember if there were presentations.
There was a provocative talk about about why we should be considering about considering research into areas where there's less resources.
Yeah, but do you remember that presentation then? Yeah. And
I don't think he spoke to specific funding opportunities within that.
Yeah, I think the same speaker, I saw him talking in another presentation, and it was all Well, maybe, yeah, I don't know, maybe he was doing it just with his own academic budget or whatever. But I'm pretty sure that that person may have some knowledge about how to navigate this collaboration between University of Bristol and some other country.
Who did you find that? No.
No.
He does a lot of co-design work in Southern America. So I wonder whether you guys could put him in touch with Christopher. Because I feel that would be good.
Yeah.
Do you know, can you tell a little bit more to him? What is Novo's work or not?
So Novo work. I mean, he's done a lot of different projects, but he did some work with I think it was with pregnant women or and
in a rural population.
And there was a lot of kind of like socio-cultural issues to consider in terms of what a woman would be able to say if there's a man present, where actually then it wouldn't be like socially acceptable to say certain things. But he did also speak about like the practicalities of this is actually at the end of it in the Q&A, because he delivered a talk like this up. And he went on about I guess research funding and how it was like feasible and trying to like keep project costs like
low as possible. Yeah. I feel like he'd be a really good person to put in touch.
Yeah.
Did he give a speak?
Yeah, in the seminar.
From Cardiff, yeah. And then there's the record. Oh, it's not the recording online.
No, he didn't want to be recorded.
Oh,
okay. Because he had PhD students that were awaiting Viva, and he was talking about some of the work they did. He didn't want to like get to interfere, basically.
I see.
Do
you think at some point that could be uploaded? Well, we can contact him.
It wasn't recorded.
Oh, it was not.
No, he didn't want it to be recorded, so
okay.
We didn't record it.
But he was one of the speakers. It's listed on the blog website.
We can send you his email. I've got his email.
Yeah. Nice. I know him fairly well, so I can easily put you in touch.
Okay. Thank you.
More questions?
I've sort of had a question on the tip of my tongue, so sorry if this is a bit waffling, but I think it's interesting. I guess there's lots of things that are specifically relevant to this context, but how much would you say? How much would you say is specifically relevant to Uganda versus low resource countries as a whole, versus like the healthcare system, and like just healthcare systems in general? Like, what would you say is the most like specific to Uganda?
I think what I've seen from other settings, even in Africa, I've seen some countries who have implemented digital health systems at point of care, but it feels so surprising, like we are still using hard copy registers. Even the real tool, which is a hard copy tool, has not yet been fully translated into an electronic version. It could be something easier, but I don't understand why it is not yet done. Because even us, when we are doing this data extraction, we had to create our own into RedCap. If there was a digital one from maybe the ministry, would have adapted to that and then just convert the data from the register into the books, but it didn't happen. So I don't know what else maybe would be so specific, but I think there is a big gap Yeah, the biggest one I would say is we don't have data for research. There is no relevant data, and that one sometimes beats my understanding. As a patient report to the facility every day, we have an opportunity to have this data collected, and it's not collected. And I've been seeing I mean, for example, the postnatal care, where we expect patients are supposed to be measured their blood pressure. In the register that we currently have, there is no variable for blood pressure measurement. So I wonder whether the patient goes in the clinic and they're not measured their blood pressure, or it's measured and it's not recorded. Yet it's one of the key indicators, that's blood pressure. It's a key indicator for most of cardiovascular diseases. So if we don't have all these measurements taken, what are we really monitoring? What can we do without data? Advancement, for example, in use of machine learning is taking place all over the world. But testing all those models and whatever, they require data, real, practical, setting specific data, which we don't have. Would be, for example, applying the risk Q3 model in our setting, because all the variables that are in that model can easily be got in Uganda, but we don't have that data. So how can we apply it when we don't have the data? I think, that's why the foundation of our this organization, MIHRI, is at that, creating data that can help us develop research, train models, or even help us monitor interventions. Because it's like the government is more focused on the key indicators. For example, maternal mortality. They will report that 200 whatever death per 100,000 live birth. But what is causing that? How is that 200 coming in? What is causing that? If we keep only reporting the outcome without knowing the before, then what are we really going to improve?
But I think the difficult part is to quantify what would be the benefit of what you are proposing, how that digital system will change the numbers that you have shown, because until it's not deployed, it's not possible to quantify that, make an estimate. And you could compare what are the statistics, the mortality statistics there without the digital system, and what are the mortality rates in other countries that have the digital system. But there are lots of other aspects that may affect the mortality rate, which makes it difficult to identify how much the digitalization is improving the mortality rates.
Yeah.
Then, I don't know, maybe by trying to identify similar hospitals with similar conditions than the ones that you are targeting, but that have a digital system implemented. Maybe those are good ones to compare with and see if the mortality rates are too different or not. Because I find it difficult to know what would be the benefit. Because probably there is a specific budget for healthcare at the moment, and it may be more useful that the budget is being spent for other tasks rather than the digitalization, no? But I don't know.
So I think one other thing I found really interesting, because I've always been trying to compare with the healthcare system here, in that when you go for your medical test and whatever, and you have an appointment to come maybe in 2 weeks or 3 weeks, there is that automated message that you normally receive to remind you about your appointment. And sometimes it pushes me to go and attend a medical visit just because I got that message. But now, in our setting where there's no kind of reminder about your appointment, so many patients are missing their visit. For example, those in delivery and antenatal, they are very structured. When you attend today, they tell you you're supposed to come back maybe in the next 4 weeks. But the 4 weeks will come just because this mother did not feel any complications. She will not come. And not all complications can show sign. So missed appointment is one of the things that I think this system can improve. And also, what I would also emphasize that is, if we are creating data using this system and then we are testing models, at the very point of examination for this patient, we can easily predict the outcome of this mother during delivery and during the postnatal period. So when we predict the outcomes, we can easily re-emphasize this patient to come back, because some of them don't give it attention to come back to the facility for delivery. They end up, for example, I showed you 15% giving birth at home because they feel they don't have the risks. But if we're able to predict these risks are enough, then we would re-emphasize with the patient that, you know what, the moment you know you are in these days of ranges for your delivery, make sure you come back to the facility. Because some of them don't come. I know there are challenges related to transport, the economics, and because they don't have money to come back, they end up delivering from there. But others just relax because they feel they are not at any risk. But if this risk was assessed early enough, maybe it would help us to improve the attendance as well.
Do all the patients have access to mobile phones?
Yeah, at least the mobile phone accessibility is high. They may not be smartphones, but the cell phone that can receive messages. At least that one has improved. Yeah, most of the people have phone numbers.
So do you have any funding for the co-design, or is that what you're trying to get?
Yeah, that's what we're trying to get at the moment. No funding. Yeah.
Your PhD, your PhD pot.
The PhD pot has been reduced.
The PhD.
I know that too well.
Yeah. So it's a big challenge.
The other thing that I was thinking all the time, when you were mentioning that some hospitals don't have, that one patient can visit different hospitals at different points.
Yeah.
And then they may not report their national number or health number and all of this. But something that it's always common is that the person is going there. And I was thinking if only the person had a smartphone and all the data from the visits were recorded in their own phone somehow. That could be already their identifier somehow, and they would keep record of all of their data. I'm not saying that it's easy for the hospital to share that data with the phone, but I think in the future it would be great if everyone within their phones they are actually recording all their visits to all the hospitals and all their tests that they are doing, instead of relying on one hospital being able to transfer that to somewhere else.
There has been some papers on like health passports that like the patient will hold. But from the very small amount of work that I've done working with the resource countries, you cannot expect people to even have like a working browser on their phone.
That's what she mentioned.
I think it's very challenging to they're just, if there isn't the resources there, there's not the reason, there's not those you have.
Yeah. And I don't think it's only the access to the mobile phone, because here we have all mobile phones, but still the technology is another thing. How to share that information between any hospital that you visit and your passport, health passport. Any other questions? Online doesn't seem to. There are no questions, but someone mentioned that the Jean Golden Institute may have some funding related to that. Yeah, no, if there are no more questions, then let's take the